Yeah, I think we are very happy that indeed in this session became clear that we should indeed integrate this coronary information that we get in this one scan, which is extremely informative about the coronary age at least. And probably in the future also when we get photo counting, we can without contrast evaluate the soft plaques. And I think I'm very happy that we have also Dr. Stillman. He is very knowledgeable in this field and will also further help on getting this paper forward. And you have, I think, a few considerations.
Yes, thank you. So as we heard earlier in this meeting, that cardiovascular disease is the leading cause of mortality in the lung screening population. It's not cancer, it's cardiovascular disease. And coronary calcium can be readily assessed from lung cancer screening CTs. It's not as accurate, of course, as a dedicated calcium score study because it's not gated and there's other technical factors, but nevertheless, you can reliably assess whether calcium is mild, none, or mild, moderate, or severe. And we know by the cholesterol guidelines that most of the lung cancer screening population should already be treated with statins, which is the critical question that you really try to answer with calcium. But the problem, of course, is that compliance with the guidelines is very poor. And I give you a reference here if you are interested. One thing we could consider is looking at the epicardial adipose tissue, because it's, again, I have a reference here for people to read if they wish. It's been found that increased epicardial adipose tissue volume and density are independently associated with increased density and all-cause and cardiovascular disease mortality, even for calcium scores of 0. And this can be assessed from the lung cancer screening CT. The data is already present on all the scans. Should we be reporting it? Peripheral vascular disease is prevalent in this population. And certainly in my personal experience, most of the patients that I see with aortic aneurysms are smokers. And here I cited another reference. In the Hamburg city, for Jens' benefit, is give him his city a plug. But we know this, and given the high mortality of undiagnosed aortic aneurysms, should we be screening for aneurysms, at least at the initial time of the lung cancer screening CT? Should we be screening for other smoking-related diseases rather than be focused exclusively on lung cancer? And I really think we're perhaps doing a bit of a disservice calling this a lung cancer screening test rather than smoking-related disease testing, which could be even other non-invasive testing. You could do ankle brachial indices as part of a screening process for peripheral vascular disease in this population. So I think that those are the main thoughts and questions I had. Perhaps you have some others that you would like to add?
I think the most important thing is that we keep it integrated and not drift to all kind of different other issues. So there was brought up that we could also screen at the same time, for example, for abdominal steatosis of the liver and that kind of region. So we should also, I think, mark what are the comorbidities that we really want to address and what are the incidental findings. And that brings also up the question if we are not, there's an enormous need at the moment from different decision levels at the European Committee, in our Dutch Health Council, but also I think probably in the United States, for more guidance on incidental findings. So we were discussing that probably we should also do the coming year a paper on incidental findings, how to define it, and comorbidities. And so calcium, I think the calcium scoring is totally integrated and should be marked as a comorbidity. So the terminology here is also very important. We should bring in also in emphysema, but also for the calcium scoring, and more or less also give the direction that those are comorbidities. For us, it's clear that it's all tobacco related, but in the literature, it's still not integrated. And so the approach of the big three was, when we started with this, I think it's 7 years ago or 8 years ago, it was not in any thinking in the literature, and here is now really breaking through. I think that's very important. And now with the emphysema coming on, we can really work first in the direction of the B3. And then perhaps we brought also up, how do we look at this bone density issue? Is it enough just to have the bone density of the thoracic vertebrae, or is it not enough? Now, that's all that kind of questions has to be answered to give a direction. And we should also connect, I think, to the Society of the Cardiologists, because they take the direction that the calcium score is only helpful to do something about the indeterminates from the other scoring techniques. And we have a different position. We think that the stratification, and that is something that will come out of the Robinska study, is primarily the best stratification, after which you then can further decide what you do with your other risk factors. So that's really turning around, and that could also be part of such a position or guidance paper, whatever you call it. So everyone that would like to join, and that goes for all the papers, upfront want to join in this endeavor for different papers, please, I think you can contact us and go further on. And that is also for this paper very important.